Assalamualaikum and good afternoon, dear ladies and gentlemen, distinguished guests and speakers. On behalf of the committee members of the Breast Cancer Resource Center, Department of Surgery, UMMC, Cancer Research Institute, Medical Genetic Units, University of Malaya, together with our partners, Together Against Cancer, TAC, Cancer Research Malaysia, Breast Surgery International, BSI, we would like to extend a warm welcome to all of you to Together Against the Cancer Public Forums in conjunction with the 7 UMMC Breast Cancer Forums and the launch of BRCA Decision AIDS. We appreciate your time taking off, especially on Sunday, to join our public forums for today. I'm Dr. Aishah, General Surgery Trainee, and I'll be your moderating for today's public forum. This year, the public forum theme is about making smart decisions on genetic testing. As we all know, the public forums now is considered as a new norm for us due to the unprecedented COVID-19 outbreak. So we hope that you'll find our programs line up most engaging and insightful for everyone. We'll be having speakers, and throughout the forums, we'll be compiling questions and queries about the topic that will be discussed today and be answered by the panels at the end of the discussions. Please type the question in Q&A box at the right bottom corner of your screen if you do have any question or queries, and please do note that this is different from the chat box. Ladies and gentlemen, it gives us a great pleasure to invite our first speaker of today, Associate Professor Dr. Seng, who is an expert in palliative medicines, to deliver the first topic of lecture for today, which is entitled How to Declutter Our Mind. Associate Professor Dr. Seng is a consultant in palliative medicines in University of Malaya Medical Center. He did a lot of research and published many articles and books related to mindfulness. Ladies and gentlemen, without further ado, let's do some spring cleaning of our mind from our daily hectic and busy life. And please welcome Professor Dr. Seng. We have no doubts here by now that Oscar-winning actress Angelina Jolie found that through the genetic testing that she is at the high risk of the breast cancer. She's actually ultimately decided to undergo a prophylactic bilateral mastectomy to reduce the risk of developing the disease. Angelina has taken very difficult and quite frankly, very personal decisions, and she's making it to the public. She shared the story with the world and use it as an opportunity to educate the women everywhere about being aware of the family histories and taking charge of their health. But bear in mind that she is an unaffected woman and she was never been diagnosed to have a breast cancer before. So the question now is actually, does genetic testing is important in uninfected women? Does it impact the breast cancer treatment? So to answer these queries, let us invite our next speaker of today, who is consultant oncologist and expert in the breast cancer treatment from the Department of Clinical Oncology, UMMC. She will highlight us on the importance of genetic profile in the breast cancer treatments currently. Without further ado, please welcome Associate Professor Dr. Marniza Saad.
Thank you very much, Aishah, for your introduction. I hope everyone can see my slide, and a very good afternoon to everyone, panel speakers, our moderator today, and our organizing team, IT crew members, and of course to all our audience out there. So this is our second round of talking about cancer and genetics. So I start with acknowledgements, right? Slides and material in my presentation, some of them are adopted and adapted from various sources, including from the World Wide Web. Now, so my topic today, right? To help us answer this question, does my genetic profile impact on my treatment? When we talk about genetic profile, genetic testing, so what does this mean? So it can be defined as a type of medical test that identifies changes in chromosomes, genes, or proteins. And the results of the test can confirm or rule out a suspected genetic condition or help us determine a person's chance of developing or passing on a disorder. And when we talk about cancer, it's about identifying the genes that put someone at risk of getting the cancers or passing the genes on. So this is, when we talk about genetic testing, usually in most people's mind, this is the first thing that comes into our mind. And you've heard about Angelina Jolie before, and I'm sure other speakers later will also mention about her story. So she's very well known, not just in the entertainment industry, but also in cancer. and how powerful genetic testing can be in making someone make a decision that will change their life. But what I'm going to focus on today, perhaps not so much of genetic testing to identify the risk of us getting cancer, but about genetic testing that can tell us whether there's certain treatment that we should have. So let's look at a bit into the biology, okay? So what is gene? When we talk about genes, right, what is it? We all know what gene is, right? But where is it located, for example? So if we take our body and a piece of tissue from our body that composed of millions and billions of cells, and we look deep into the cells, we'll find the nucleus, which is at the center that controls everything about the cell, and we'll find chromosomes, right? And these chromosomes are made of DNA. You can see here, DNA, they are double helix, they're two strands of the DNA. And genes, they are made up of genes. You can see them, right? So there's billions of genes that is contained in DNA. So what is a gene? A gene is the functional unit in DNA that carries information about ourselves, our features, how we look like, and how our body functions. So it controls everything. It's the main CPU in our body. So how does it do that? Okay, so genes actually, there's a lot of codes, encrypted messages in the genes. Okay, they may look quite simple, but they're actually quite complex. And the genes actually code for many proteins. Human body are really made up of proteins. Okay, so as you can see there, different parts of the genes may code different types of proteins, and we need these proteins to make up our body and also to control how our body functions. So it controls the growth of survival in cells, including cancer cells. So then how does cancer develop, right? So look at an example here. If we start off with normal cell, right? So cancer cells develop actually from errors that occur in the genes. As we know, the genes control cells, growth, and survival. So any errors called mutations here may result in abnormality of the DNA. So some of these errors are not that disastrous. So meaning we could develop one error or one mutation, but the cell can still survive, right? Repair the error and they survive. And then they might develop second mutation, still survive. And then third mutation, for example. After so many mutations, sometimes the mutations or the error are just too disastrous that the cancer then change into what we call a malignant counterpart of the cell. And this is essentially what happens when a cell turns into cancer. So the defects occurs in the gene. So then we can say all cancer is genetic, right? Because it all comes from the genes. But it's very important to be aware that not all cancers are inherited. In fact, only a small proportion of cancers are inherited. As you can see here, we have sporadic and hereditary cancers. Sporadic means it occurs spontaneously. So, and you can see the percentage of all cancers. Most cancers are sporadic in nature. Up to 70 to 80% of them occur spontaneously, where we don't really know the exact cause, and usually it's multifactorial. So when cancer occurs sporadically, right, there's no increased risk for close family members to get the cancers because it cannot be passed on. The mutation occurs at the somatic level. We'll look at that later. Even though the mutation may be similar to hereditary cancers, but it cannot be passed on. You can see here, for sporadic cancer, we start off with normal cell, meaning a person is born normal with no specific mutation to cause cancer, but may acquire several mutations during the lifetime, and eventually, that mutation that causes significant change that results in cancer. Whereas hereditary cancer on this one now is only 5 to 10% of cases. So hereditary cancers, we are born with it. We are born with a mutation, for example, but it doesn't form cancer yet. And in the lifetime, we may develop more mutations that results in cancer. But of course, because we already got first mutation when we were born, so the cancer can occur earlier compared to sporadic cancers. So because the mutation that causes hereditary cancer occurs in all cells of the body, so it's something that we can pass on, right? So it increases lifetime risk and also risk in family members as well. And the mutation occurs at what we call germline level. Again, we look at that later. And some of the genes involved are shown here. Most of us know about BRCA genes, but there are other genes also associated with hereditary cancers. And the way the cancer grow and behave between sporadic and hereditary are generally very, very similar. Okay. So now let's look at germline versus somatic, because I mentioned to you just now, sporadic cancers are mainly somatic mutations, whereas hereditary cancers, they started off with a germline mutation. So what are these mutations? So germline mutations occurs in all cells in the body because they start with the germ cells. When we say germ cells, we are referring to the eggs and the sperms. So meaning it started off with the eggs and the sperm, the embryo, and then the whole body contains that cell and that mutation, sorry. Whereas somatic mutation, it originates in some parts of the body only, specific tissues, for example, tumor. Okay, so it is only contained in some cells of the body. So this is another diagram to perhaps explain that better. So we start off with eggs and sperms, right? And with the germline mutation, already got one mutation, for example, and then form an embryo, and all the tissue, the cells in the embryo contains the mutation, right? And the same when we grow up, right? So that puts us at risk of getting the cancer. And this can be passed on to the next generation. Whereas with somatic mutation, right? So we were born with all normal cells with no mutation that can cause an increased risk of cancer, but later develop the mutation during our lifetime, what we call somatic mutation, and only affects certain part of the body, for example, not the whole of the body. And in cancer, we're looking at mainly the tumor that contains this mutation, and it doesn't get passed on to the offspring. So how do we test then? Now that we know how the mutations start, right? So how do we look for them? So for germline mutations, because it's contained in all parts of our body, so we can actually send any tissue from our body, but of course, most of the time we send from the blood, right? We send the blood, and we can also take a swab from the buccal mucosa, and we do tests on these cells. So this will show us germline mutations. Whereas somatic mutations, right? We're talking about cancer, then we want to look at the cells of the tumor itself. So the DNA and the genes that we extract from the tumor. So what does it show? So essentially we extract from tumor, we extract the chromosomes and the DNA, and from blood or from any tissue of the body, the same thing, we extract the DNA, and then we will read the DNA, okay? Because I told you it's encrypting a lot of messages there. So we open up the DNA and read all the sequences and find any specific mutation. So when we talk about then genetic testing, the ability for us to try and read our DNA. So there are essentially 3 different approaches and aims on how we do it and why we do it. Okay, so you can see here, we can divide into genomic, tumor sequencing, and inherited cancer testing. So genomic testing, we perform on tumor tissue and mainly to look at the whole genome of the tumor. So it gives like a molecular signature for the cancer. And this is helpful in certain situations, for example, in deciding on adjuvant chemotherapy after having surgery for breast cancer, because sometimes some patients may have very low risk such that they may not benefit. So an example is Oncotype DX. And for prostate cancer, for example, for treatment of localized prostate cancer, it may also help us decide whether a person should undergo treatment or not. Okay. Next is tumor sequencing. This is again performed on tumor tissue, but this time we're looking at tumor-specific mutations, right? And the benefit of this is really to try and find a mutation which we can target with certain targeted therapies. For example, what we're going to talk about today is BRCA mutation and the role of a drug therapy called PARP inhibitor. And next is inherited cancer testing. Okay, this is when we perform the test on blood or saliva, looking for the germline mutations, right? And we know the benefit of this is that we can try and identify whether a person has the mutation that put them at risk of getting cancer or passing it on, such that we can take appropriate measures to screen, to detect the cancer early, or to
to advocate some treatment to prevent the cancer from occurring. And in addition to that, we can also offer potential targeted therapies that can target these abnormalities. So what we're going to talk today mainly is about these two. Okay, trying to sequence the tumors for somatic mutations or our normal cells for germline mutations that can be targeted by a drug therapy that we have available. So now this is just to show you an example of the list of genetic mutations that we know of and we already have drug therapy for. Okay, so of course there's many more out there, but this is just to give you an example. So these are the example of mutation: KRAS, EGFR, HER2 in breast cancer, right? MMR and BRCA. So these are the type of cancers, right? Various cancers and the different drugs that can be used in patients, you know, who have some of these mutations or do not have some of the mutations. So now, if you look at here, right, we're going to look at number 7, which is BRCA mutation that can occur in patients with breast, ovarian, prostate cancer, and also pancreatic cancer. And there is a drug therapy, a targeted therapy that can be used now called PARP inhibitor, and these are some of the examples. Right, so the spotlight is on BRCA, okay? Of course, we're talking, speakers later will also talk about BRCA and how you know, we screen for it and we identify the risk and what can we do to reduce the risk. Okay, but my discussion today is mainly about trying to target this mutation and offer treatment in patients who already have the cancer. So spotlight is on BRCA, but in order to understand how it works, right, we need to bring in PARP and also PARP inhibitor into the picture. Right, so let me tell you the story about DNA repair first so that you understand how this works. So imagine this is our DNA, and I told you it's formed by 2 strands, what called double helix structure, right? So all the time DNA get damages. Okay, you can see here these are all some of the examples, but the most common is just random errors when DNA is being replicated when cell division occurs. So there's millions of DNA damages occurring, you know, every second. So I want you to focus on 2 types of damage. If you look at here, right, you have 2 double helix structures of the DNA, and when you have one break, you know, a break in one strand, we call that single strand break. Okay, and when we have breaks in both of the strands, and usually they are quite close together, we call that double strand break. So these are 2 types of DNA damages. Of course, there are many others, but these are the 2 main ones that I want you to focus on. Of course, we need to repair these breaks, right? So for single strand breaks, we have PARP protein to repair them. Whereas for double strand breaks, we need BRCA protein to repair them. And if you look at the extent of the damage, then we know double strand breaks is a more significant damage because it involves 2 strands. Right? So if we cannot repair this, the cell cannot survive. So it will result in loss of a lot of genetic information, such as the cells cannot survive, and if it's not repaired, the cell will die. So what about PARP inhibitor? So PARP inhibitor is not a protein made by our body, it's actually a drug, right? So you can see here, these just 4 examples of the drug that has been approved for treatment currently, but there are a few others still being investigated. So what does PARP inhibitor do? Okay, so this is the bad guy in a way, okay, because PARP inhibitor actually inhibits PARP. So remember just now I told you PARP proteins actually go and repair the single strand breaks. So PARP inhibitor, it binds to PARP protein and stop it from doing the repair. Okay, so how does it then work with BRCA? So let me tell you the story of PARP inhibitor and BRCA. I know it looks a bit complex, but it's a very simple story. You just have to follow me. Okay. So if you look at this damaged DNA, that single strand break because only one strand is damaged. And I told you already, PARP is a protein that's needed to repair. So PARP will get activated and it will bind itself to that broken area. Okay. And PARP will need some help. Okay. So it will call upon all many other DNA repair crew members, right? And they get attached together and they work together in order to repair it. And then the end result is the normal DNA sequence again, and the cell are able to divide and survive. So this bad guy PARP inhibitor comes into the picture. All right. So what happens? You have your PARP protein already attached there, ready to work, right? But PARP inhibitor comes in and binds itself to PARP. And when it does that, it stops PARP from functioning. Okay, so there you go. So it cannot move, it cannot function. And after a while, right, it will create more damage and resulting in double strand break. So from a single strand break, we now got double strand breaks. Okay, so what will happen? And I told you just now, double strand breaks are repaired by BRCA proteins. So in situation where we have normal BRCA genes, right, this is not an issue, this is not a problem at all, because BRCA protein will then come in and they start repairing, and then you're going to get a normal DNA again and the cells survive. But what happens if this occurs in cells that do not have BRCA protein that works, what we call BRCA mutation? Okay, the genes are mutated, so it doesn't produce normal BRCA proteins. So it cannot repair the damage. And I told you double strand breaks cannot be repaired. It will result in cell death. So that's how these three components work, you know, PARP and BRCA proteins with the drug PARP inhibitor. So this is to summarize. If you have a PARP inhibitor that targets the PARP, right, creating double strand break, in normal cells, this is not a problem because it can still be repaired. However, in cancer cells that have DNA repair defects, this cannot be repaired, therefore it results in cell death. So then, how do we use PARP inhibitor in cancer? What evidence do we have? So currently, many PARP inhibitors or several PARP inhibitors have already been approved to be used in cancer. And I show you here the four main tumor sites, the cancer types: breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. With BRCA mutation, where we already have evidence of PARP inhibitor giving a benefit. Okay, and I just show you this is the evidence. All right, don't get too worried. This is the only slide that shows quite technical information. So I'm just showing you some of the many studies, 2 in breast cancers and 1 in prostate cancer. So if you look at the breast cancer, olaparib and talazoparib, they are 2 different PARP inhibitors, but they were used in advanced breast cancer and in those patients with germline BRCA mutation. And they compared with standard treatment like chemotherapy. These are patients already had treatment with chemotherapy and also hormone therapy, and then they've been found to have germline mutations in the BRCA gene, and they were randomized, or they were compared between olaparib or talazoparib and the standard treatment. And these are just survival curves to show that there are benefits. When you see a separation, you know, it shows that the 2 drugs, the 2 treatments are different and in favor of PARP inhibitor. And the same goes to prostate cancers, right? This is olaparib in advanced prostate cancer or metastatic prostate cancer that has failed chemotherapy and standard hormonal therapy. So patients all had BRCA mutation and also a few other mutations of genes that's involved in DNA repair. And it compared between olaparib and the standard of care, other hormone therapy. And again, it shows this big separation between the 2 curves in favor of olaparib in these patients. So if we look at the guidelines now, right, it already incorporated BRCA gene mutation. So this is for breast cancer. So it suggests that we should do germline genetic testing to detect for germline mutation in the BRCA gene so that we can consider PARP inhibitor as part of the treatment options. Of course, there are many other treatment options like chemo, hormonal, and other targeted therapies. So this is just one of them. And the same goes for prostate cancer. So the guidelines suggest now we should do testing. And for this one, we look at for both tumor and tissue to look at for both germline and somatic mutations to see whether patient can benefit from PARP inhibitor as one of the treatment options. So then we've seen how genetic testing, right, do guide in terms of our treatment. So this is what we call precision medicine. Essentially, we want to move from what's in the past and more or less still in the current where one treatment fits all. We treat cancer based on the cancer type. So all patients get the same treatment, even though this is still very important for a lot of patients. But for many patients, we want to be able to offer personalized treatment. So we want to be able to identify the defective or the errors or the molecules that's important in certain growth and survival pathway of the cancer, so that we can target this with specific targeted therapy. Therefore, the chances of the treatment working will be much higher. And really, this is the principle of precision medicine, where if we can identify that predictive or that molecular biomarker, so essentially any types of tumor that has that biomarker may potentially benefit from the targeted therapy. So then, if we go back to this question, does my genetic profile impact on my treatment, right? So I hope based on what I have discussed with you, you would be able to answer this. But of course, I hope you will see the benefit of doing the genetic testing. So the answer of this should be yes. That's the end of my talk. Thank you.
Thank you, Prof, for such an informative talk regarding the genetics. So we move on to the next sessions. Who typically get a genetic testing? People who think that they are high risk of breast cancer may think about genetic testing, but people who actually have a family history of breast cancer may consider they should get genetic testing being done. But however, not everyone with the breast cancer in the family should have got this test being done. So the question is, who should do the genetic testing? To answer this question, we would like to welcome the expert herself when it comes to the breast cancer risk and awareness, who is no stranger to the surgical fraternity and whose work and contributions have expanded the field of breast surgery over the years. Please join us in welcoming Professor Dr. Nur Aishah Muhammad Taib, Director of Cancer Research Institute and the Senior Consultant Breast Surgeons, Department of Surgery, University Malaya. Please welcome, Prof.
Thank you, Dr. Shah. Okay, so I think we have had a lot of talks about this morning about understanding the genes and all that. And then I think Prof. Tan Seng Beng, our star palliative physician, mindful expert, has also helped us declutter our minds. So let me just quickly get into the business of breast cancer risk and awareness. So a bit of outline, the breast cancer, I will be talking a bit about the Malaysian statistics, a bit about risk factors, awareness on symptoms, screening in women with no symptoms, how to make a diagnosis, and what strategies we can do as a member of the community. So I'm not going to go too much into details, but essentially our lifetime risk in Malaysia is not as high as the West. We're about 1 in 27. It's more common among the Chinese and Indians compared to the Malays. Okay, and we can see breast cancer remain the most common cancer. If you put men and women together, it still makes up about 19% of all cancers in Malaysia. This slide just shows you the common cancers among the male and female. So the colorectal cancer is actually a very important cancer nowadays, and also lung cancer and cervical cancer. This is to share with you the how common is cancer in Malaysia compared to if you compare with people from Singapore. Okay, we can see that our rates are actually quite low compared to even the same races in Singapore. And to share with you, our survival rates in Malaysia, unfortunately, is not as good as our neighbor in Singapore, as well as in China, and of course, like Japan has probably the highest survival rates for breast cancer. All right, so the problem we see in our country is actually we have a lot of people coming with late stage cancer. It can, unfortunately, when we did some trending in nationally using the National Cancer Register, you can see that the rates of stage 3 and 4 has actually increased from the previous report from 43 to 47.9%. So we know that the outcomes of cancer is much dependent on the stage of cancer. But again, when you look at stage 0, our survival rates is very good. It's about 100%. But as you get along the staging, the survival rates have become less. But even when the cancer has spread, stage 4, the survival rate still can achieve up to about 20%. So this data comes from our government side. So a lot of our patients have problems with access to modern innovator drugs because of the cost. So that is why I think our survival rates for stage 4 is not as high as what is reported if you look at national figures, because in the private sector and if patients have insurance, they may be able to afford more innovator medicines. So I think I would like to bring about your attention that in Malaysia, we don't actually have a population-based screening for women for breast cancer. I think rightly so. Just to share with you, when we say screening for cancer means that the patient has not had any symptoms yet. Once they have symptoms, we want to aim towards early diagnosis. That means detecting symptomatic cancers at the early stage, like especially stage 2, stage 1 maybe, but most of the time symptomatic cancer is stage 2 breast cancer. All right, so this is some data from the states showing that at the point of before they started mammogram screening, the survival rates actually improve. So this is the mortality incidence ratio. That means the death rates over the incidence of breast cancer in the US. So you can see the steep decline in the mortality incidence ratio happened even before screening mammography. When the introduction of mammography was somewhere in the mid-70s, there was still further reduction, and they think it also could be due to the more effective adjuvant treatments like chemotherapy and other biological therapies. Okay, so how do we assess risk? So I think a lot of people, not sure. Am I high risk? Am I low risk? Am I average risk? How do we determine this? So unfortunately, in Malaysia, we still do not have like a mathematical model that will help predict our risk as an individual. Like what is happening in the West, where all these models are made from Caucasian patient data. So we are looking forward to future data from Malaysia itself. So we're still waiting to be able to have models like that to predict our risk. Nonetheless, from the Malaysian clinical practice guidelines, certain risk factors have been put to be important. Okay, so you can see there are non-modifiable risk factors and modifiable risk factors. So when it's non-modifiable, it's like our age. As we get older, the risk of cancer increases. Being a woman definitely increases risk of cancer, but of course, breast cancer can also be seen in men, but only 1% of breast cancer patients are male. Okay. The other thing is family history. When there's a history of breast cancer at a young age, that family may actually have a genetic predisposition. And of course, carriers who have the genetic predisposition, they are definitely high risk. Okay. Reproductive factors like young age at having her first periods less than 12 years old increases risk slightly. Late menopause when they're more than 50 years also increases risk. Okay. And certain history of biopsy results from the breast may increase their risk. For example, something we call atypical ductal hyperplasia, or we call it as ADH or LCIS, okay? Or someone who has had breast cancer before or DCIS before. These people have a higher risk of developing another cancer in the opposite breast, okay? The other thing that people don't know about is the breast density. So breast density is measured by mammogram to see how dense the breast is. And there is a way to categorize the density of the breast. Okay, now we look at the modifiable factors. So there are reproductive factors like not ever having children increases risk, lack of breastfeeding, older age at having the first child. This all has a higher risk of breast cancer, although not terribly high. Okay, and oral contraceptive pills may also increase risk. Overweight, obesity throughout adulthood is a risk factor for breast cancer. Physical activity, increased physical activity actually reduces risk. So if you want a magic figure, you should need to do something like 150 minutes per week of brisk walking or 75 minutes per week of running. Green tea is protective if you take more than 3 cups a day. Coffee may have some reduction in risk. Okay, soy reduces risk and alcohol increases risk. For people who have had radiation exposure as children, especially for people with non-Hodgkin lymphoma where they have radiation to the lymph nodes in the chest, they may have a higher risk of breast cancer and they should be screened. So if you look at all this, there's nothing really that we can pinpoint our finger on except for family history. But only 30% of our breast cancer patients actually have a family history. So most people do not have a family history. But if you do have a family history, you need to learn more so that you can manage that risk. So when we take a family history, we usually do a 3-generational family tree. So if it's the mother, then if the person who has cancer comes to the clinic, we will take 2 steps away from her and 2 steps below her. So if it's a woman in her 30s who have siblings, we will take that as their first degree. Mom is first degree. Daughter is first degree. Okay, father is also first degree. So remember, both mother and father side may actually transmit the gene. So how do we know that person may be high risk? So if the family history of breast cancer diagnosed before the age of 45 in the family, or the family member could have triple negative breast cancer or ovarian cancer, bilateral breast cancer, or breast and ovarian in the same person, breast cancer in a male relative, okay, that's generally for BRCA2 gene mutation, okay? And now, as what Prof. Marniza has mentioned, prostate cancer, pancreatic cancer, these are all markers of possibility of BRCA gene carriage. Okay. There are also other genes that may be involved. So someone who's got bone cancer, brain cancer, this may actually denote a syndrome called Li-Fraumeni syndrome, where they are also high risk of developing cancer. Okay. All right, if a member of the family has been tested and has been found to be a carrier of BRCA, that itself makes that person a high risk person. Okay, but of course, if the genetic test results are known, if it's negative in a high risk family who has the BRCA gene mutation, then most likely that person does not have that risk from similar to their relatives with the BRCA mutation. So just to share with you, when someone has been, the gene does not transmit 100% of the time. So if a person has, like the mother is pregnant with, let's say, every time she's pregnant, that child that has been conceived only has a 50% chance of actually receiving the abnormal gene. Okay. So let's go to breast density. So breast density can be measured on the mammogram. So if you if you're going for screening, if your breast density is category C or D, that means it's very dense, because breast is made up of the glandular tissue, fibrous tissue, and fat. The more fat you have, the less the density of the breast. So the problem with having dense breast is that cancer is white. So white on white, you cannot see it very well. So it can also mask the cancer. So if in Malaysia, our radiologists are quite good in the sense that they actually make sure that if they are not sure in dense breast patients, they actually will do an ultrasound. Okay. But a normal mammogram, especially if it's a dense mammogram, may not be very useful in terms of detecting the cancer early. All right, so I'm just going to go through the symptoms of breast cancer. The common cancer that we know of, the commonest symptom is a painless breast lump. Nothing else. Patient is well, can function normally, go to work or work at home, whatever, but then she is normal, she only has a painless breast lump. So the early signs are that, and nipple discharge as well as nipple rash. The rest of the symptoms and signs like orange peel skin, ulcers, okay, or large masses with dilated veins, these are all quite a symptom of more advanced disease. Okay, so how do we detect a cancer? So when a person finds a symptom, should go and see the doctor first. And the doctor will then examine the patient and see whether there's any lump. If the doctor is not sure and the patient does have a new symptom, she should be imaged. So the patient can undergo ultrasound or mammogram depending on the age group. So anyone 35 years and above can receive a mammogram which is diagnostic in nature. Once the imaging has been done, then a biopsy is done. And once the biopsy is done, then only we can say the examination is complete. Sometimes what happens that young women, they have lumps, they go to a doctor, the doctor may say, oh, this is a mobile lump, you're only 30 years old, it's unlikely to be cancer. So I would have to say, as a community, a member of the community, you should be aware that if you are at that age, 30 years, and you have a lump, it's not enough to have the doctor examine you. You need to have an ultrasound at least to make sure that we have not missed a cancer. Okay, so examination is only 50% accurate. You need to go for other imaging tests. All right. So actually, I'm quoting a lot of things from the Know Your Lemons materials. You can actually go to their website and look more and understand more what to expect. But one thing that they teach is that what are you feeling when you examine the breast? Okay, so if anything is hard and firm and stuck to the breast, okay, it doesn't move very much, that is a suspicious lump. But if something is soft, like peas, especially if it's clumped together and soft, these are usually the nodularity of the breast. Okay, so that's not something you should worry about. But whatever it is, if you detect something new, you should go and see a doctor to confirm. Okay, so we do have a Malaysian practice, clinical practice guideline that we've just, I think just published like last year. This is the 3rd edition. So you can see from the Malaysian clinical practice guideline, if you are 35 years and above, okay, you have any signs and symptoms as we mentioned before, or you're in the high risk group, doesn't matter what age you are, and you have signs and symptoms, okay, then you should be referred within 2 weeks to a hospital or a clinic that can do diagnostics. That means biopsy and all that, okay? All right. When we talk about screening, we're talking about people with no symptoms at all. So they are quite well, they've decided, I want to find out if I have any early breast cancer, I will go for my checkups. And I'm prepared that if I find something, I might have to do biopsies and all that. So that is something that all of us could do. And this is what we call opportunistic screening. So when in some countries where they give population, they have population-based screening, you get an invitation to a mammogram center, screening center. But unfortunately, I don't think anyone 50 years and above have gotten any letters, right, to go for screening. So it is up to you and it's up to your doctors who are going to advise you. So in Malaysia, the recommendation is for women 50 to 74 years of age to have screening mammogram every 2 years. Okay, if you are average risk, that means there's no high risk or anything like that. But if you're between 40 to 50, you have an option of doing mammogram screening too, if you do not have any high risk factors. Okay, but if you're high risk and you have no genetic test done, you can consider doing mammogram even as early as 30. It depends how old is the youngest person in the family. So usually we take about 10 years before the youngest person in the family, but we won't do mammogram anywhere below the age of 30. Only 30 years and above, we would do mammogram. Okay. All right. If the patient has a genetic change, BRCA1, 2, PALB2, and MRI can also be added on into the screening protocol. Okay, once they reach 50, if the breast is no longer dense, they may actually just benefit from yearly mammogram. So if you have been to a mammogram screening facility and you may find that you have all these reports, right? You don't understand what they mean. Okay, so what I have to say is that even your GPs may not understand what it means, especially if the report does not report very well. So one thing you got to worry about is the quality of the mammogram itself. The second thing you need to worry about is to make sure the report that is done is of quality. Okay, because the decision making on what to do next really depends on the radiologist's report. Okay, so I'm not going to go into details, but just to say that be careful where you go for your mammograms. Okay, not all mammograms and reports are created equal. Okay, all right. What happens in a mammographic area? Of course, there's compression of the breast. Okay, in the past, people are very scared of compression because it is quite painful. All right, but nowadays with the newer machines, the compression is much less than before. Okay, so and of course, the women, the people who manage or handle the breast during the compression and all that are women only. Okay, this is law. Okay, only female radiographers are going to handle women's breast during the mammogram examination. And of course, people are always scared of radiation, but you can see here that the average radiation for a mammogram is very low, actually, if you compare to the average annual background radiation. But of course, this is in the US. But even in the higher radiation areas, like in Colorado and all this, the radiation dose is actually quite low. Okay, so there's the worry about high, radiation causing cancer is only probably important in people who have very sensitive DNA, certain people with certain family history and some genetic predisposition should not have mammogram. For example, the Lee-Fraumeni syndrome that I mentioned earlier. Okay, so I think I'm not going to go into too much details of this, but you must know there are limitations to a mammogram. There could be dense breast, okay, or there could be the lobular cancer type that doesn't form a tumor, but it forms, like a lot of people call it the Indian file. Indian file means, you know, you walk in a row. I mean, nowadays you can't say that, like, it sounds so racist, okay, but then essentially the cells line up in rows rather than form a clump of tumor. So what happens then, you cannot see a mass on the mammogram. The patient probably would just complain that her breast is getting much more firmer. Okay, and this can be quite difficult to detect sometimes. So if you find a change in the shape of your breast, please insist or see an experienced doctor who will be able to diagnose this. Okay. All right, of course, there's overdiagnosis of slow-growing cancer. So in the West, the question is, should they do mammogram in everybody? You know, so there's two camps. One camp says, let's carry on the screening, it's really improved the survival of women. There's a group saying, oh, we are only screening those cancers that are not going to affect you. Okay. Unfortunately, we do not know who is going to have the slow-growing tumors that will not affect you. So I think in Malaysia, we still recommend opportunistic screening. Okay. All right. Okay, so benefits, we know that we can detect cancer earlier stages. Okay. The rate of pickup should be in the region of about 5 in 1,000. Okay, in targeted, that means in high risk people, you should find for every 1,000 women screen, you should find about 125 cancers. Okay, so I put this up, think before you pink, because this is a common myth that tumor markers is going to be the best test ever to detect early cancers. So this is very not true at all. There is no rule for tumor markers. So I'm afraid all that very expensive tests you do every year does not really help, because tumor markers may be falsely negative. That means even cancer patients, you do the tumor markers, it could be normal, or worse, it could be falsely positive. That means the tumor markers is raised, but you have done all the checks and all that, you cannot find a cancer, and that person cannot live, cannot sleep properly for the next 2 years. Okay, so before you do any tumor marker screening, please discuss properly with your doctors. It is not a screening tool, full stop. Okay, and then the other thing that we should think before you pink is that you should not be going for ultrasound screening. So we have a lot of young women in their 20s going for health checks. And one of the things in the package is a breast ultrasound. The problem with that is that ultrasound is not very good in terms of, it's very operator dependent. It depends who is doing it. Okay, and it doesn't show microcalcification very well. Okay, And the problem really about ultrasound is that once you find an abnormality, these women have difficulty getting insurance coverage for that breast disease. So you'll find that they will be covered for other diseases, but not breast cancer. So it really defeats the purpose of trying to help people to get coverage for their later years if they have problems, okay? So before you do ultrasound, please, this is not a screening tool. The only evidence-based screening for breast cancer right now is a mammogram. All right, and of course, as I told you, all reports are not created equal. You have to be careful because sometimes you have to pay double, you know, because you got one report that does not give very good quality reports. Good quality reports help clinicians, doctors like myself, like our GP friends, to actually determine what to do next. If you get a report that is not so clear, it's going to be difficult and you wasted that amount of money, you have to do another one, okay? All right, so I think I've mentioned this already. Just to share with you, in our recommendation, digital breast tomosynthesis should be considered for screening and diagnosis based on its availability. So as mentioned just now, not all mammograms are created equal. Some have better accuracy and more sensitive in picking up things. So we call it the 3D mammogram or the tomosynthesis, okay? All right, so I'm not going to talk too much about this, but when you find a lump, you will go through some tests. So mammogram, ultrasound, and then the biopsy, right? So this is why all women who go for screening should be mentally prepared that if you go for screening, you may end up having a biopsy, because we've seen many women, they just go follow their friends, do a mammogram, and then suddenly when they find something, they panic, you know? So you have to be prepared that maybe when you do mammogram screening, you're well, but you might find something there that you need to do something further. What happens when you go for screening? Sometimes when you find a mammogram abnormality, you need to go for a biopsy. And that biopsy sometimes may be needed to be done during the mammogram itself, okay? Or much better if it's found also on ultrasound, and ultrasound guided biopsy can be done. So how do we remove these lumps and tumors? Because you cannot feel the lesion is very small, we will use wire localization. So our friendly radiologists will help to localize this before the operation. They put a small wire through. And don't forget, all biopsies done under local anesthetic. A lot of people are so scared of pain. And I think we have to respect that everybody is worried. I mean, I wouldn't want to go for a test that is going to be very painful, right? But a biopsy is done under local anesthetic. All these procedures are done under local anesthetic. Okay? All right. So screen detected cancers are usually, when found early, you can actually end up with a lumpectomy. You may not need a mastectomy. Okay? All right. So that is almost my last slide. Okay? I just thought I'll share with you some resources that you may be, you want to know more about breast cancer. You can go to our Breast Cancer Resource Center UMMC YouTube channel. And just to share with you, people who are living in PJ, we are going to look forward to having multi-sectoral collaboration to improve the quality of care for cancer in Greater Petaling, which really is PJ, Subang Jaya, and the surrounding areas. So we are one of the cities in the world who is going to embark on this. So we hope that we can definitely improve the quality of care in our part of the world. Okay, I'm not going to go into too much details because I think time is almost up, but I will leave with this slide that these are the healthy habits that has been found to be evidence-based to prevent cancer, okay? So control your body fatness, okay? Keep your BMI in check. Plant foods for protein has been found to reduce risk, okay? Physical activity, as mentioned before. Try not to take any alcoholic drinks, okay? Food and drinks that promote weight gain, okay? And then all the preservation process and all this less salt, all the processed food and all that, you shouldn't take those foods, okay? Breastfeeding can be protective, okay? Animal foods may actually increase risk. And dietary supplements does not prevent cancer. So I think this is very important. This is the World Cancer Research Fund International. You can actually Google them. They only put out reports that are evidence-based, okay? So in conclusion, early diagnosis is something that in our country we should focus on. People need to know what the symptoms are. Okay, screening mammo can be done when you have no symptoms at all. And the average risk women should do their mammograms at least from the age 50 to 74 years every 2 years. For high-risk women, you can start with mammogram MRI 30 years onwards, and this can be done annually. And then do not do tumor markers. Okay, and that was my last slide. Thank you.
Thank you, Prof, for such an informative talk. Right, moving on, we would like to call upon our next speaker for today, who is a genetic counselor in the Cancer Research Malaysia. She's also the head of Familial Research Program and a graduate from University of Cambridge. Ms. Yoon has been involved in the Malaysian breast cancer, also known as MyBRCA, research project at the Cancer Research Malaysia since 2003. She is one of the 2 certified genetic counselor in Malaysia and is accredited by the Human Genetic Society of Australia. She will highlight us on the next topic of discussion for today, entitled, "Is a genetic result useful for me?" Without further ado, please welcome Ms. Sook.
Good afternoon, and thank you, Dr. Faris, for the kind introduction. Good afternoon to everyone here today. I am going to carry on with a slightly different topic. And I think from the previous speakers, we've heard about the genetic test, a description of the BRCA genetic test in particular, how it's used for treatment options, how it's used for risk management, and so on. I'm going to move on to how do you make a decision then? What is important to consider when trying to decide if a genetic test is useful? So some of the more common questions that we get from individuals, say for someone who have cancer, is, does that mean my children will get cancer too? Is that something a genetic test can help me confirm? Or there are some individuals who says, oh, I know and I've heard that there are breast cancers in my family and I'm worried. I don't have any issues right now, but I don't know if I'm going to be the next one. We do also have individuals who come up and say, actually, it was my doctor who asked me to do a genetic test. I'm not really sure, but I think it's supposed to be to see if I can use a new drug for my treatment. Or we also get questions and queries and say, I saw this really interesting advertisement for genetic tests on Facebook, and it seems like such a good idea. And they now have a promotion. If there are 2, we get, if 2 of us take the test, we'll get a discount. So these are some of the queries that you may have yourself as well. And we're just going to walk through how are we going to look at what are the things to consider while trying to make a decision on doing genetic tests. So just to summarize from the previous discussion, the utility of a BRCA genetic test is primarily, firstly, can provide information about the cancer, can identify relatives or cancer patients who may be at increased risk of cancer and gives them the opportunity to manage their risk. And this is for the individual herself as well, for the risk of any other cancers that may occur. In addition, and more so currently, it can also be used for clinical decisions about treatment and drugs that can be used. So these are generally the main reasons that BRCA testing is brought up. But in order to think and get the right information about whether or not to do a genetic test, then genetic counseling becomes quite important. So the purpose of genetic counseling is really to give information about the genetic condition, explain about the inheritance pattern and the risk assessment for the individual, to understand what the available options are for treatment, so that in the end, the individual can make an informed choice, right, that is suitable for their personal and family situation. And this will enable them to help adjust to the condition and the risk that they may have. So what goes on in a genetic counseling session, and what is genetic counseling? Essentially, a lot of it is about getting the right information, the correct and accurate information. Most of it you have heard of today as well, but to be able to break it down into ways that you can actually grasp and understand fully. This will eventually lead on to benefits and limitations. So we have all heard about the benefits, but we also need to understand the limitations of genetic test. Because these are information that may have impact on the individual self-health, and also impact on the family, sometimes there are or may be psychological consequences. So it is always useful to be prepared on what the outcome might be and to manage the expectations appropriately. We have heard about the genetic test that could be germline as well, which means it can lead to an inherited pattern in a family. But if you are the custodian of this information, so you find out information that may impact family members, who else would you tell in your family? Who are you close to or not close to? What about the guilt of not sharing if you're not close to someone? Some of these need to be discussed before a test is done. And in Malaysia, the legal framework for using genetic information is not well structured at the moment. There's a lot of ongoing work in trying to sort that out, but there will be confidentiality concerns. Some individuals are worried in terms of insurance. Some individuals are worried in terms of what the impact may be on their employment. Ultimately, it is a personal decision that can be done jointly in a shared decision-making framework together with your clinicians. You hold the power to decide because it is your genes, and you should be able to have all of the empowerment for you to make that decision. Is it something that you would like to know? So in this case, counselors do come in. We need to explain that the genetic counseling may not necessarily only be done by the genetic counselors, but the genetic counselors are the ones that are specifically trained for it. And we are now moving on to also training other healthcare providers like the oncologists, like the surgeons, to be able to provide the genetic counseling as well. So in Malaysia, there are some counseling services already in clinical genetics facilities that are set up in several hospitals throughout the country. And as you can see here, there are several sites that you can actually go to and get a referral from your own doctors if you want to have a appointment with a genetic counseling session from either a clinical geneticist or a genetic counselor. But what's important is ultimately what influences your decision on a BRCA genetic test. We know that knowledge is very important because that will help you understand the whys and why nots of having to do the test and how it's going to impact on your risk or your treatment. Right? But there are always many other factors when we make decisions. There is always, there could be discussions with family members, with our significant other, our partners, spouses, and so on. And in Malaysia, we know that that is a very important part of our decision making, and especially when it comes to medical and health decisions. There are cultural and religious influences as well, and everyone has their own leanings. You know, there is no particular right or wrong when it comes to this sort of information. So what are the tools that can help us with this process? So you would have seen that in the flyer, we will be launching decision aids later, just after this session. And I'm just going to take a little bit of time to explain to you what decision aids are. So it sounds rather curious, a decision aid, you know, what exactly is that? So decision aids are a tool, different types of tools that is developed to guide and help individuals to make informed decisions. So they are planned in such a way that it will give you all of the information that you may need in order to come to a decision that takes into account all of your influences when it comes to decision making. So the best option depends on a patient's perception of the harms and benefits. So that is very much part of what the decision aid is. It is also designed so that it can increase the individual's participation in decision making. So I think Prof Aishah also has alluded earlier, about how in Malaysia it's quite a paternalistic pattern when it comes to healthcare decisions. So it's always what the doctor says. It's always the way to go, or the question is always, what do you think, doctor? What do you think? Should I be doing this? Well, when it comes to genetic testing and genetic counseling, we are giving a little bit of more of those decision-making power to the individual, and together with the right tools, it can help to give you more participation in the decision making. But the decision aid is a tool to enhance. It does not replace the patient professional communication. So the ultimate goal of the decision aid is to help patients understand the risks and benefits, to help the individuals clarify the values, and to help the individuals make decisions which are consistent with these values, so that ultimately you are comfortable with the decision that is made. So there are 3 decision aids that are going to be launched later. The first one, which is about making decisions about genetic tests for inherited breast and ovarian cancer. This booklet is particularly for the decision making on the BRCA genetic test itself. So it gives you all of the information about the test, what sort of risks, how to manage with the pros and cons of the testing, and it will also come up with a table that will guide you on how to make the decision that you want. The second decision aid that will be launched today is the breast cancer prevention decision aid, and this is particularly for women who already have a BRCA genetic change. So this decision aid guides on how to select a risk management process or decision that is most suitable for someone who already has a BRCA genetic change. And this is for the risk of breast cancer. The third decision aid is managing the risk of developing ovarian cancer. This is also specifically developed for individuals who already have the BRCA mutation, and it helps them manage the coming to decisions on what sort of and how to proceed with risk management for the ovarian cancer risk. So this is a set of 3 decision aids that will be launched later. And this will be rolled out eventually to all of the clinics so that it can be used together with your healthcare provider. So it could be your oncologist, it could be your surgeon, it could be your genetic counselor or clinical geneticist. And this is meant to help you with how to make a decision on genetic testing or the risk management for carriers themselves. So in summary, we know that BRCA genetic testing is important for risk management and treatment decisions. So we know that there is the utility that is important for those that require it. However, in order to make the right decision at the right time, it is important to have genetic counseling. And the genetic counseling can be provided by genetic counselors or the clinical geneticists, but more and more so you can also rely on your healthcare provider, your oncologist, your surgeons, and even your family GPs will be able to refer you to the right individuals that can give you the proper genetic counseling before a test is ordered. And thirdly, we have developed tools. These are tools that will help to make these decisions, and they have been developed to suit what our local population needs are to support the genetic counseling process. So I would like to acknowledge the team members that are involved in the development of all of the decision aids, and also the funding bodies for Cancer Research Malaysia, Yayasan Saim Dabi, Yayasan Petronas, MSD Golf, King Starfish Foundation Research, and Tarek Fox Run. But also a special thank you to all of the patients and their families for participating in the MyBRCA, MyOFCA, and the MAGIC projects, which has led to the development of these decision aids. So in my last slide, I'd like to say thank you again for joining me in this session. But there will be, if there are questions about genetic counseling and what you should do, because genetic counseling sometimes it's quite personal. It may not be questions that you may be able to share on the chat or in a Q&A box. And especially if you have something that is personal or that is about your family history that you would like to discuss, please contact us at these hotline numbers. These are our genetic counseling hotline numbers, and we'll be able to guide you through the process as well. Thank you.
Thank you to Ms. Sook for the interesting and excellent presentation. Ladies and gentlemen, we have come to our main event for today, which is officiation and launch session for these forums. I would like to welcome our distinguished guests, Yang Amat Berbahagia, Toh Puan Datuk Sri Hajah Dr. Aishah Ong, who is a Pro-Chancellor of University of Malaya. Yang Berusaha, Prof. Dr. Nur Saadah Abdul Rahman, Deputy Vice Chancellor, Research and Innovations, University of Malaya. Yang Berusaha, Prof. Dr. Nazira Hasnan, Deputy Director Clinical, University of Malaya Medical Center. Yang Berusaha, Prof. Tong, Head Medical Genetic Units, UMMC. Yang Berusaha, Professor Datin Paduka, Dr. Teo Su Huang, Chief Scientific Officer, Cancer Research Malaysia, CRM. Yang Berusaha, Prof. Nur Aishah Taib, Head Cancer Research Institute. And last but not least, Yang Berusaha, Ms. Yoon Suk Yi, Genetic Counselor, CRM. Welcome to the Together Against Cancer Public Forum in conjunction with the 7th UMMC Breast Cancer Forum and the launch of BRCA Decision 8, which consists of making decisions about genetic tests for inherited breast and ovarian cancer, how to manage risk of developing ovarian cancer, and last but not least, breast cancer prevention decision aid for women with BRCA genetic change. This decision aids has been developed by the Cancer Research Malaysia team, led by Ms. Yoon and Ms. Tiara, and two of our PhD students, which is Ms. Grave Yoh Karsi and Ms. Hamizah binti Haji Saad. This again supervised by our Professor Dr. Nur Aishah and also Dr. Lee Yu Kong. Without further ado, I would like to invite Yang Berusaha, Prof. Dr. Nur Saadah Abdul Rahman, Deputy Vice Chancellor, Research and Innovation of University Malaya, to deliver her speech, and to invite Yang Amat Berbahagia, Toh Puan Datuk Sri Hajah Dr. Aishah Ong, Pro-Chancellor of University Malaya, to grace us with her speech and to officiate the launch of BRCA Decision 8. Please welcome.
Thank you, Dr. Fairuz. I hope you can hear me. Assalamualaikum warahmatullahi wabarakatuh. A very good afternoon. Yang amat berbahagia Tuh Puan Datuk Sri Hajah Dr. Aishah Ong, Pro-Chancellor Universiti Malaya. Yang berusaha Prof. Dr. Nazira Hasnan, Deputy Director Clinical Universiti Malaya Medical Center. Yang berusaha Professor Dr. Tong Miao Kiong, Head of Medical Genetics Unit UMMC. Yang berusaha Professor Dr. Datin Paduka Dr. Teo Su Huang, Chief Scientific Officer Cancer Research Malaysia. And yang berusaha Professor Dr. Nur Aishah Talib, Head of Cancer Research Institute. Distinguished ladies and gentlemen, I would like to welcome everyone to this auspicious event to launch the hard work of our PhD students and researchers. Although we have been climbing up the rank, Universiti Malaya has been ranked 59th among the top 1,000 universities in the latest edition of the QS World Ranking. We still have a lot of work to do. I am very honored to see the fruits of our research impacting the community directly. Research impact is the effect of research that is beyond academic. Research impact as when the knowledge generated by our researchers contributes to the benefit and influences the society, culture, our environment, and the economy. Furthermore, interdisciplinary collaboration between molecular genetics, clinical care, and patient decisions, as well as experts between organizations such as Cancer Research Malaysia and Universiti Malaya can produce meaningful impact to the patients. I understand the collaboration dates back to 2003 with the Malaysian BRCA study or my BRCA study that characterized the predisposition to inherit that breast cancer and formation of BRCA risk management clinic in breast clinic services in UMMC and the UMMC Medical Genetics Unit in 2009. Although the lack of a specialized manpower and career pathway for allied health professional remains problematic in public hospitals, UMMC is able to employ a genetic counselor and have a visiting genetic counselor for the formation of the risk assessment genetic clinics in 2016. The translational aspect of the genetic research to practice can be challenging, but possibly a great teamwork. The COVID-19 pandemic has brought about innovation in our campus. Congratulations to the organizer for providing your event to a virtual online event within a short span of time. Also, congratulations to the Faculty of Medicine in forming the visible unit to leapfrog this innovation. It is also humbling to see about 120 numbers of attendees during this public forum and 50 in the clinician webinar. I'm happy to hear that many are not digitally natives, but the oldest attendee is an 82-year-old person. Our Malaysian community is more active online nowadays compared to the days before the COVID-19. Because they consume content and information online, they work from home, you can also reach out to international attendees instantaneously. It is definitely something that has eliminated barriers for attendees to join such events. With that, I would like to thank the organizer, and also I'm very honored to invite Yang Amat Berbahagia Tuan Puan Datuk Seri Dr. Hajah Aishah Ong, our Pro-Chancellor, to deliver a speech and to launch the decision aids. Thank you.
Terima kasih banyak-banyak Prof. Dr. Nur Saadah Abdul Rahman, Deputy Vice Chancellor Research at the University of Malaya. Thank you so much for your kind words. And I must thank all the speakers. I've really enjoyed the entire 2 hours, and I've learned so much. Although I'm a doctor, I'm really a bit out of date. And really, thank you so much for what I've learned today. Thank you so much. So with this, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yang berusaha, Professor Dr. Nur Saadah Abdul Rahman, Deputy Vice Chancellor in Research, University of Malaya. Yang berusaha, Professor Dr. Nazira Hasnan, Deputy Director, University of Malaya Medical Center. Nice to see you, Prof. And Yang berusaha, Professor M.K. Tong, Head of the Medical Genetic Unit at the UMMC. And Yang berbahagia, Datin Paduka, Professor Dr. Teo Fuang, Chief Scientific Officer, Cancer Research Malaysia. Yang berusaha, Professor Dr. Nur Aishah Taib, Head of the University of Malaya Cancer Research Institute. That was a very good speech. Thank you so much, Prof. I really enjoyed that. And also my colleague at Cancer Research too, Ms. Yoon, Genetic Counselor at Cancer Research Malaysia. Thank you very much, Soo-Ee. That was a good speech. And all distinguished speakers and guests, welcome. First and foremost, allow me to thank the organizing committee for inviting me to officiate at today's historic event, the launch of very important tools for decision-making in this era of genetic medicine. It certainly is a new era for me because I was in medical schools in the 70s. Ladies and gentlemen, we live in a time of unprecedented advances in the use of genetics in healthcare, and there has been vast improvements in the use of genetic tests for risk management and treatment options. One such use of genetic information is the BRCA genetic test. You've been listening to that for the last 2 hours, which you have all heard of so much about today. I would like to congratulate Professor Dr. Nur Aishah, who is the head of University of Malaya Cancer Research Institute, together with her partners, that is the Cancer Research Malaysia, and the group that called itself Together Against Cancer, for organizing this very educational public talk for the 7th UMMC Breast Cancer Forum with the theme, Making Smart Decisions on Genetic Testing. I would also like to congratulate the team led by Professor Dr. Noor Aishah and Ms. Yoon from Cancer Research Malaysia for developing the Decision 8 series for BRCA genetic testing as with for breast cancer and ovarian cancer risk management. Producing impactful research output to help patients and their family members has always been the aim of the University of Malaya. Well done. Decision aids, as explained by Sook just now, are tools that help patients make decisions about their medical needs. And in this case, it is about the use of BRCA genetic testing to find out if the individual has an inherited genetic change that will increase her risk to certain cancers like breast and ovarian cancer. We have heard of Angelina Jolie and the story of her BRCA journey. I think it's well known to most of us who follow the Hollywood journey. Well, we now have our own made in Malaysia for Malaysians decision aids to help Malaysians through their own BRCA journey here in Malaysia. Again, well done to you ladies. This is very timely because in Malaysia, the use of genetic testing in diagnosis and treatment is following the trends as seen in many other developed countries. We are really moving forward. However, we have to ensure no one is left behind in the use of genetic testing. Therefore, I am very pleased to announce that the Decision 8 for BRCA genetic testing is specially developed for low literacy users to suit our population. For this, the team would like to acknowledge the collaboration of our international collaborators, Professor Bettina Mieser, Professor Chris Barlow Stewart, Dr. Sean Smith, and Dr. Rachel Williams from Australia. Dengan lafaz yang mulia, Bismillahirrahmanirrahim, it gives me now great pleasure to officially launch the 3 decision aids, which are 1, making decisions about genetic tests for inherited breast and ovarian cancer. 2, how do I manage the risk of developing ovarian cancer? And thirdly, breast cancer prevention decision aid for women with BRCA1 and BRCA2 genetic change. Sekian, wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. And congratulations again.
Thank you to our guest of honor for such an inspiring speech and launching the BRCA Decision Aid. This completed PDA will be further researched in a complex randomized controlled study. Once again, we would like to thank you to Yang Berbahagia, Prof Puan, and all our distinguished guests for this event. Thank you. Ladies and gentlemen, we will continue our event with a scheduled lecture subsequently. Earlier on, we have decluttered our mind. Now it's time to declutter our body to be fit and healthy. Next session will be conducted by the two prominent speakers, Associate Professor Ho Go Fuang, who is a consultant oncologist, University of Malaya Medical Center, and also by Dr. Eddie Chan Seng, who is a nutritional and lifestyle medicine physician. Without further ado, please do welcome Associate Professor Ho and Dr. Eddie Chan.
Good afternoon. Thank you, Virus. So this talk was originally called, is there a special cancer survivor lifestyle? That's what Aishah asked me to talk about. The short answer is no. But I still kept the short title. At least that is a question that we have been asked. I'll talk for 10 minutes and then I'll leave 15 minutes for Dr. Eddie to talk about decluttering the body, which is a fantastic talk. I heard him talking recently. If I want him to share, to be able to share with our TSC audience. Our knowledge about whether you can prevent breast cancer recurrence or not comes from two major studies. The first one is the Women's Interventional Nutrition Study, called WIN study. That was published 14 years ago. So the study screened 68,000 people, and then they recruited 2,400 subjects, and then they allocated the patients to dietary intervention group to reduce basically dietary fat, and the control group, which is the control arm. And the study basically showed that by reducing dietary fat, mainly saturated fat, you can reduce the chance of breast cancer relapse at 7 years with a hazard ratio of 0.76, means reducing the risk of breast cancer relapse by 24%. So it is a positive study. The effect seems to be contrary to intuition, more obvious in the ER negative subgroup rather than ER positive subgroup, but it is positive overall nevertheless. If you look at the detail, when we look at studies, you have to look at the detail that what happened to the patients. The saturated fat at baseline control, the control arm and the intervention arm were both 18.7 grams. After 1 year, the saturated fat intake dropped significantly in the intervention arm, and in subsequent years, the reduction was sustained. Again, equally important, the dietary fibers intake went up after 1 year in the intervention arm, and that effect was sustained over the 5 years of the study. Also, we noted that the weight of the control arm and intervention arm was 72 kg in both arms, but dropped after 1 year in the intervention arm by 2 kg, and this effect was also sustained for 5 years. Therefore, when you introduce a lifestyle intervention program, the program needs to be successful and actually did what it's supposed to do to generate the effect. The second study from in JAMA, also from 13 years ago, called Women's Healthy Living and Healthy Eating and Living randomized trial, look at 3,000 patients. This basically they are looking at whether introducing a diet very high in vegetables, fruit and fiber, and low in fat can improve the prognosis of breast cancer patients. If you look at the detail of this study, this is the intervention arm and control arm. The energy from fat was 28%. After 6 months, it dropped in the intervention arm, but the effect was not really sustained. It went up again back to baseline after 6 years compared to the control arm, which also went up as well. So the effect was actually quite short-lasting for about 1 year only. If you look at the energy intake from the intervention arm, this is the control arm, it went down for both arms, and actually was similar in both arms as well, because the control arm subjects also did lifestyle changes when they're in a study. But significantly, the weight of both arms in the participant in both arms, it did not change. In fact, it went up more in the intervention arm than in the control arm, 74 kg in the intervention arm compared to the control arm after 6 years. So this study basically was completely negative, did not generate any relapse-free survival for the intervention arm group. Therefore, we had, in the short span of 2 years, one study that was totally positive and very convincing, and one study that was totally negative. So it becomes very confusing for healthcare providers like us. We don't know what is the role of dietary and lifestyle intervention. When they look at the subgroup analysis, they found that patients who are free from hot flushes, actually they did not so good. But the survival improved when they participate in the study. The hypothesis is that for patients who had high circulating estrogen concentration, that's why they don't have hot flushes, they benefit more from the intervention of low saturated fat and more dietary fibers and fruit and vegetables. In terms of chemo prevention, i.e. dietary prevention, we call chemo prevention, there are a few meta-analyses that give us a bit of idea. One would be carotenoids. Carotenoids, we're talking about, today we're a dietitian here, alpha carotene, beta carotene, lutein, and lycopene. Alpha carotene is the yellow-orange vegetables like carrots, sweet potatoes, pumpkin, dark green vegetables like broccoli, green beans, spinach, and avocado. Also beta carotene, also in same fruits and vegetables as alpha carotene. Lutein is a very good phytochemical that prevent cancer, heart disease, macular degeneration. Is related to lycopene, and it's found in a lot of fruits and vegetables, including peaches, oranges, cruciferous vegetables, according to Memorial Sloan Kettering Cancer Center. And lycopene is a phytochemical found in tomatoes. In fact, cooking tomatoes seems to make it more effective, make lycopene more effective than eating raw tomatoes. So if we look at the epidemiological study, the higher serum concentration of alpha carotene, beta carotene, lutein, and lycopene is related to low risk of developing breast cancer. So high carotenoids in the diet seems to be protective against breast cancer. That's what we know. The next phytochemical is flavonoids. This is another meta-analysis from a few years ago. So flavonoids is in this study, they have 12 studies, including 9,500 cases. And they found that there are two types of flavonoids, flavonols and flavons, both related to reduced risk of breast cancer. Hazard ratio 0.88 for flavonols, and flavons was hazard ratio 0.83, means reduction of risk of breast cancer by 12% and 17%. But they found that other subclasses of flavonoid was not effective. These are the two effective subclasses, and particularly effective for postmenopausal women. So flavonols also include two types, like the broccoli, which contains quercetin, and green tea, which contains catechins, but also flavons. But we don't eat so much of flavons like skullcap. But flavonols, anthocyanidins, and soybeans, they were not shown to be particularly effective for breast cancer prevention. So this is the outcome of the meta-analysis. So these flavonols and flavons have basically, when you look at this diamond shape, if it does not cross midline, that means it is a positive effect on the prevention. So what is the rationale behind this? They feel that maybe the plant-derived food as a source of chemopreventive compounds, but also it may lower the circulating estrogen concentration. And the phytochemicals with more evidence include carotenoids, polyphenols, and isothiocyanates. But also they found that the carotenoid lycopene inhibits insulin growth factor 1 which is not so good if it is elevated in patients because it is a kind of growth hormones for breast cancer. So what do we know? We know that the phytonutrients has inhibitory action on breast cancer cell proliferation from many cell line and early phase studies. The observational data support an inverse relationship between phytonutrient consumption and risk of recurrence. So that we do know. What we don't know is a direct interventional study by introducing these phytonutrients and see the effect on estrogen and IGF-1 and on the breast cancer patients. So it's not easy to make it into a compound and run a phase 3 clinical trial based on diet or dietary compounds, because diet, when you eat fruits or vegetables, it contains a lot of phytonutrients, not just one or two. What does these 4 food have in common? Green tea, turmeric, broccoli, and pomegranate. These 4 food items has been investigated in a UK NCRN POMI-T study because they all contain a lot of polyphenol phytonutrients for prostate cancer patients. In the introductory part of the paper, they say diets deficient in polyphenols and other natural plant-based phytochemicals found in herbs, spices, fruit, tea, etc. Link to higher risk of cancer, particularly breast, pancreas, ovary, and prostate, bowel, esophagus cancer. And they thought that polyphenols actually is useful for breast cancer sufferers because if they take higher levels of fruit and vegetables, they have the lower recurrence, and lignans, isoflavones, flavonoids, and soy-rich foods and green tea consumption gave a lower risk of breast cancer death. So in this study, they make it into a capsule, broccoli, turmeric, pomegranate, and green tea in this kind of concentration, and basically feed this to the prostate cancer sufferers who are not on treatment. So what they found is that for patients who took this dietary, phytonutrients, actually their PSA did not rise compared to patients who are on observation alone. So that's percentage rise. In fact, it dropped somewhat compared to prostate cancer patients who are on follow-up alone. Therefore, these phytonutrients has been proven in a randomized controlled trial to be effective against prostate cancer. In terms of colon cancer, in this paper, they say that colon cancer more common in patients, in people in Western countries because of high consumption of meats and fats, and Asian diet, which has a lot of phytochemical-rich fruits and vegetables, they tend to have lower risk of developing colon cancers, and they think this one is because of genetic and epigenetic. Genetic is what is born to you when you were born. Epigenetic is what you do to your cells when you grow up and exposed to all the environmental factors. So the chemopreventive and therapeutic efficacy of these molecules via modulation of epigenetic signatures, i.e. how you handle yourself and what you eat and what you do later in life actually changes the epigenetic signatures. So it is not just what you're born with, but what you do with yourself also has an impact. So this is a study from Japan. Basically, they use green tea as a prevention for colon cancer, and they concluded that drinking 10 Japanese-sized cups tea, which is 120 ml per day, delay colon cancer onset by 7.3 years among females and 3.2 years among males. So green tea, which has a lot of phytonutrients, most importantly is catechins, seems to have chemo preventive effect against colon cancer. So in the plants and vegetables of different colors, white color, purple, green, yellow, red color, they all have different phytonutrients. And then these are basically gift from the higher power to us human to keep us healthy. Finally, I have to talk on exercise because exercise is an important part of prevention for cancer recurrence. This study, there are many studies, I just quote one, supervised trial of aerobic versus resistance training, START trial. Basically, patients who exercise regularly, this one was during chemotherapy for breast cancer patients, they have better disease-free survival, better overall survival, and better relapse-free survival, distant metastasis-free survival, and lower rate of recurrences. So actually, this kind of effect we see it time and again in many different studies. Is another study that says that the amount of hours the patients spend walking each week, if they spend little time walking, the chance of dying from breast cancer is a bit higher. If they walk to this kind of metabolic hour per week, actually the chance of dying from breast cancer reduced. If they walk some more, they do some more exercises, then the chance of relapse gone down. So in fact, in JAMA, they actually have had a meta-analysis and concluded that the more exercise you put in each week, either by walking or by jogging, then the chance of mortality, which is dying from the breast cancer, goes down. But there is a limit of how much you can achieve. 39% risk reduction of death if you walk for 420 hours, which is 7 minutes, which is 7 hours per week, or running for 135 minutes, which is running for about 2 hours per week. That will achieve the maximum benefit you get from exercise. So exercise and healthy diet reduce the fat in body, increase skeletal muscles, reduce insulin growth factor 1, reduce leptin, which is produced by fat and inflammation, and reduce aromatase enzyme and estrogen, and that will reduce tumor progression and reduce risk of recurrence. And dietary, so this is the recommendation from this paper that we need to take less protein we need to take protein low and saturated fat, basically take more protein from plant-based diet, avoid processed meat, which is a carcinogen, and then obtain nutrients from food sources rather than from supplements, take more omega-3 rather than omega-6, which is more in animal protein, animal fat, and exercise regularly. Okay, time is very short, so I would like to introduce to pass the mic to Dr. Eddie, who is actually an expert in nutrition, because as doctor we don't know much about nutrition, but he actually had a diploma in nutrition as well. So Dr. Eddie.
Good evening, everybody. Today I would like to compliment on what Dr. Ho have mentioned about food for cancer. Okay, he always asks a lot of questions about food for cancer. So of course there are many foods that can increase the risk of cancer. So you try to identify the risk first, then later we may mention about what else we can do about it. Okay, so we all know that a low fiber diet can increase the risk of cancer. Okay, because fibers actually can absorb the toxin and come up from our gut. Okay, includes hormones, all kind of carcinogen, etc. So there's research shown that if you have colon cancer, stomach cancer, and breast cancer, actually less common with high fiber diet. So another risk is high fat diet, okay? Especially saturated fat. Okay, research shown that animal fats intake higher, the chances to get breast cancer is even higher. Okay, so before Second World War, actually Japanese living in a pre-Western diet have very few cases of cancer. Their fibers intake was high and fat intake was low, about 15% of the total calorie. However, after Second World War, when Western diet come in, the incidence of cancer is getting higher and higher. So the research shown that the optimum reduced risk of cancer, actually the diet should be a low-fat diet, less than 20% of the total calorie from the fat. But you look at that, less than 20% of the total calorie from the fat. Salmon is already 40%, beef is 28%, lean beef already 28%. Remove the skin, skinless chicken is 24%, tuna is 21%. Our broccoli is 10%, brown rice 7%, beans, lentil 3-4%, apple, orange 2-3%. So you can see that usually plant have a much lower fat compared to the meat product. Actually, now they start to show that whatever oil we added in, oil is a processed food as well. So the third risk we are talking about is animal protein. We know that animal protein, when it get burned, when it get cooked, especially burned, okay, they develop heterocyclic amines, is a carcinogen. Okay, there's a researcher called Prof. Professor Colin Campbell. He's an emeritus professor in the Cornell University. He done an extensive research in nutrition in China for 20 years, in 65 towns in China, working with Oxford, Cornell University, and China University for 20 over years. There are many results that will come up. Okay, one of the studies is very interesting. They inject a toxin called aflatoxin, inject into the rat. Okay, to see the liver cancer. Okay, start to develop precancerous lesions start to develop. So 3 weeks later, they found that they give the rat 20% of the animal protein, 20%. Okay, the cancer index start to rise up with mutated gene, precancer lesion. Then they shift the protein diet to 5% again. Okay, for another 3 weeks, they found that regressions of the precancerous lesion. So they increase the protein again 20% for another 3 weeks again. They notice cancer index have increased also. Then later they reduce the protein to 5%, okay, for another 3 weeks. They found that the lesion also regressed. So this shows that amount of animal protein do have impact of our precancerous lesion. Okay? So this is one of the studies showing that female colon cancer incidence and daily meat consumption as a positive relationship. So he reached a conclusion that the people who eat the most animal protein have the most heart disease, cancer, and diabetes. And just because of this research, Professor Colin Campbell, he is a meat lover, okay? And finally, he changed to plant-based diet, and he mentioned that whatever I do, I just follow the science and the data. So this is another study that showed that high-fat animal protein and low fibers can associate with increased cancer risk. So how do you define a high-protein diet? Actually, high-protein diet is defined as 20% of your total calorie come from protein. It's called a high-protein diet. You can see beef already 38%. Just now, Professor Hall had mentioned about the protein. It should be about 10 to 35%. Beef is already 38%. Chicken is 48%. Salmon is 66%. Okay, so the risk of cancer have 3 things we need to be aware. First, low fibers increase the risk. High fat, especially more than 20% of your calorie. High animal protein. This is all risk of cancer. So take a high fibers, low fat diet is very important. Okay? So because it can reduce 40% of the cancer cases. Now the question is, food for prevention is good, okay? Does it help in treatment as well? Okay. Many people get cancer, we always get the feedback is, eat whatever you want, just follow your normal diet, balanced diet, right? Okay. So when we stop to cancer, we know that when you stop smoking, your lung cancer won't get cured, okay? However, does it mean that you need to continue to smoke as usual, since stop smoking doesn't help? But research shown that stop smoking does help in your chemotherapy, does help the treatment more effective, and stop smoking also reduce the risk of cancer recurrence. Same like diet, actually the same thing. Okay, colon cancer patients who increase their fibers intake after diagnosis have a lower death rate. Every 5 grams per day increase of fibers intake associated with lower death rate. Okay. Also, greater survival after breast cancer in physically active women with high vegetable fruit intake. Okay. Vegetable intake also associated with reduced breast cancer recurrence. Okay. So risk of dying from breast cancer also increased by 40% if every 1 kg of fat the women consume per month. Okay. So this is the same thing. So basically, especially in breast cancer women, they found that eat fattier food, meat, dairy products, and fried food, greater rate of cancer recurrence. So now the more and more science show that many food that help to prevent cancer, okay, chemoprophylaxis, chemoprevention, also help to improve survival when cancer has been diagnosed. The question is how to eat. We all want balanced diet, right? How to eat. Okay. We know that this is all our food. We need nutrition, right? Okay. There's no doubt about that. Wherever protein and calcium from the beef, from the pork, from chicken, all come from lower level of grass, wheat, and corn. So actually, all the protein come from, calcium come from all the vegetable and all the whole grain. But is there any difference if we eat a lower level or eat a higher layer? So which one got lower fibers? Which one got higher fat? Which one got high animal protein? Is the second level. So indirectly increase our cancer risk. Average, okay, adult, a healthy adult average, okay, you need about 50 grams of protein per day. Okay, cancer patient, they need about sometimes about 18 grams of protein per day. Okay, so let's say you have nothing to eat. Let's say just eat spinach day and night, eat until you get full. Okay, roughly you get spinach, you get 195 grams protein per day, more than your enough. Okay, same tofu, you eat day and night, you get 212 grams of protein. Of course, I don't wish you to eat tofu and spinach day and night, eat the same thing. You eat different things. But it does show that, okay, plant-based, okay, plant provide enough protein, and most plant now have been proven have complete protein. Okay, it's overturned the last time people said that plant actually don't have complete protein. Another issue is, then we know that animal iron can absorb better than plant iron. Okay. However, in research shown that vegetarians are not likely to have iron deficiency anemia compared to non-vegetarian. Because why? Very funny. Plant protein is absorbed based on your body needs. You need more. If you need more iron, okay. Let's say you are pregnant, okay. You have suffered from iron deficiency. You eat plant protein, your absorption will be increased. Animal iron, regardless of whether you need it or not, they still absorb. That's why when we take iron tablet overdose, we can get acute iron poisoning, because all these are come from animal iron. So animal iron will absorb into the body, regardless whether your body need it or not. They will still absorb. So what happened? Okay? Iron is very important to produce red blood cell, but iron absorption too much. Iron actually is a pro-oxidant. It's not antioxidant, it's a pro-oxidant. Okay? Pro-oxidant can create inflammation in the body. That's why one systemic and meta-analysis has shown that heme iron, means animal iron, is linked to cancer as well. Okay? Some of you may have to do some blood tests to check a ferritin level. You can see a sky-high ferritin level. It is a marker for inflammation. Ferritin also checks for iron storage as well. So when we eat food, we are not eating just because of protein. We're not eating just because of calcium. Actually, it's a package, okay? You eat the whole thing. You need to see the overall outcome if you eat the food, okay? We're not eating just for the protein itself. Let's say for the fish. We know fish got protein. We know fish got omega, right? We love it so much. But we also know that 84% of the fish contain unsafe level of mercury, okay? And 1 in 40 women have mercury level above recommended, also above safety level, which is effect on the fetus, okay? This is one of the patients, 3 years old, come with a learning disability. You can see sky-high mercury from the hair, okay? So because mercury in the brain, it takes about almost 10 to 20 years to come out from the body. And majority of the mercury intake is come from food, especially fish. Okay? Not only mercury, there's a compound called PCB, come from all this chemical, okay? Industrial chemical. They found that this is a group 2 carcinogen, and mainly in the fish oil and fish, because PCB is fat soluble. Okay, so let's say salmon fish and wild salmon. I don't think you can find wild salmon in Malaysia. None. All the fish, all the salmon can see it's a farm salmon. See the white strip, very beautiful white strip. All are fat because they're in a farm, so very fat. Okay, the color is orangey color. Original salmon are all gray color. Okay, they are not dark red color because they eat some algae in the sea. Okay, that's why, or krill. That's why they get the red color. In farm salmon, you don't have algae to eat, so they all are gray color. So we have to feed them coloring to produce the color based on the color chart that we want. Okay, and all this color actually developed from petroleum. Okay, and all these farm salmon have more saturated fat, 8 times more PCB. They all are dyed. Okay, we want fish omega-3 because of antioxidant level, right? Okay, not an anti-inflammation. Okay, omega-6, we know that it can cause more inflammation because they produce more AA, arachidonic acid. So all these contain AA, is not good, definitely. Pork, burger, donuts, okay. Fish even higher. Salmon, 1,000 over mg of arachidonic acid cause inflammation in the body. In fact, some study even shown that those women on vegan, they have high omega-3 because omega-3 come from plant. Fish don't produce omega-3 because they eat algae and seaweed. That's why fish got omega-3. Farm fish no omega-3 unless you give omega-3 to the fish. Okay? So why not eat the first level instead of eating the fish together with all the toxin and chemical? Okay? Chicken, the example, all they contain arsenic. They detected arsenic on the feather because they frequently use it to feed the chicken so the chicken can grow faster and the color is pinkish in color. Right? And now the group, the whole picture come to clear. WHO classification, what can cause cancer? Okay, group 1 carcinogen, okay? They can cause cancer. Hot dog, bacon, salami. You can see arsenic is in chicken. They can cause cancer. Smoking is group 1 as well. So if you're eating hot dog, it's something like you put your secret on the pans, on the cooking pan. PCB, that's the one 2A, together with pork, beef, and lamb. Okay, all the red meat. Okay, so they are the group 2A carcinogen. Okay, so American Dietetics Association, I mentioned at all stages of life, actually, plant-based diet can produce nutrition enough help for prevention and treatment on certain disease. Treatment included heart disease, diabetes, reversal as well. So since they talk about cancer, we talk about things later. Okay, so finally, food is a package of nutrients. When a package, okay, it's a package. You cannot say that I love my husband because I want my husband got a brain of the Batman and the hand of the Spider-Man. It's a package. So if you eat meat, you can get a lot of protein, definitely. But at the same time, you can bacterial toxin, hormone, and pesticide. Why got bacterial toxin? Because the meat contains bacteria. They produce toxin. If you cook the meat, bacteria die, but the toxin remain. They're heat resistant. Enter our body can cause inflammation. Pesticide in the meat can be 7 times higher than pesticide can be higher than vegetable because all these farms that eat the corn, the wheat, have high dose of pesticide. They can have inflammatory fat together, higher animal protein, no probiotic. They can destroy probiotic pattern in your gut and lead to different type of chronic diseases. This is a package. How about protein? Protein can come from the beans. They're less chemical, more fibers, okay, more plant iron, more phytonutrient. There are 100,000 old type of phytonutrient, phytochemical. I just Prof mentioned, increase of probiotic production and also reduce of chronic diseases. This is another package. You have a choice. Which one you want to choose? Okay. USDA, 1992, they developed a food pyramid. You can see the chicken on top there. Okay, small amount. Okay. 2001, they don't even mention chicken at all. They just put protein and let you choose. Okay, they just put a protein. Okay, I'm not sure, but in Malaysia we still put a fish there. Okay, in Malaysia people put fish there, but in US they already put a protein there. Okay, USDA. Okay, so 20515 dietary guideline. The first time they listed plant-based diet is one of the healthy food. You should be included inside. But of course, we mentioned that we want to eat balanced diet, right? Is balanced diet equal to eat all types of food? This is a definition. A diet consists of proper quantity, proportion, the need for health and growth. Meat is not a healthy food because of saturated fat, there are inflammatory fat, cholesterol. They are not healthy food. They are not part of the balanced diet definition. Okay? So I'm at College of Lifestyle Medicine. Recently, last year, came out, they have their own plate. Okay, so if you want to eat proper healthy diet, should be half of the plate should be fruit and vegetable, 1/4 should be whole grain, and another 1/4 from the plant protein. Plant protein means all kind of beans, nuts, tofu, antamame, all kind of nuts, and drink water. Okay, add herb and spices because herb and spices contain a lot of antioxidant, many anti-cancer property is inside the herbs as well. And with add herbs, okay, your food become more delicious, okay, so that you can continue your low fibers, low fat, and high nutrient dense diet. Okay, thank you very much. I hope all of you can follow the same diet pattern. Thank you.
Thank you to Prof. Fuang and Dr. Eddie Chan for a very useful and excellent talk regarding dietitian and healthy lifestyle. Ladies and gentlemen, next on the list, we would like to call once again our speakers for panel discussion and also the Q&A session. In addition, we'd like to invite Prof. Rahman, who is a consultant radiologist, to join our panel of discussion. I will now hand over the session to Prof. Aishah to moderate the sessions.
Okay, thank you very much. Wow, we have many questions. I've been trying to group them together, so bear with me. Okay, so I suppose we could start off with Prof. Marniza, because there's a question asking about someone who has got ovarian cancer, which was stage 4 in 2015, but responded well to treatments, and now she's got a relapse in the liver. She's not had any BRCA test done. Can you respond to that, Prof. Marniza?
Thank you, Aishah. I think maybe Fuang can help me because I've not treated ovarian cancers for so long. But based on the evidence that we have currently, I think there is an option to discuss about doing the germline mutation for BRCA, because there is an option to use it to use PARP inhibitor in this case if, let's say, she undergo more treatment. Isn't it correct, Fuang?
That's right, yeah. So PARP inhibitor has been upgraded to primary maintenance treatment after chemo. If they have BRCA mutation, they can take PARP inhibitor upfront, and that will reduce the risk of recurrence.
Okay, I think there was a related question about after having removed the prostate cancer, discovered one lymph node was affected. Now he's on hormonal treatment. Would genetic testing help in knowing risk of other cancer development? Do both of you want to respond to that?
Right, I'll take that one first then. Thank you, Aishah. So I think it depends on what the question means, because if we talk about whether there is a risk of getting more spread of prostate cancer itself, then maybe not quite. But if it's talking about whether this person can develop other cancers other than prostate cancers, then of course, if someone with prostate cancer is shown to have a germline mutation in the BRCA genes, then yes, of course, they could develop other cancers, but of course, it depends on the chances of that happening in their lifetime. So I think in the situation of recurrent prostate cancers, in someone who have germline mutation, perhaps the risk of the prostate cancer recurrence causing more problems may be higher than developing new cancers. Again, that depends on, the extent of recurrences and how long we're talking about, how long survival are we looking at. But certainly we should talk about checking for the mutations, either germline or somatic, in terms of trying to plan for the subsequent treatment, because we know the data has shown for patients with prostate cancer who later develop disease progression, right? PARP inhibitor is an option in those with BRCA mutation. But of course, for this patient who has only nodal disease, depending on what type of treatment he's getting, that might not be a treatment that we would discuss at this point. I'm not quite sure whether that is quite straightforward.
Yeah, I suppose, as you said, it really depends what stage the cancer is, and
that's
whether
right.
the PARP inhibitors can be used for metastatic prostate cancer at some point, right?
But of course, I think, sorry, Aishah, can I just add to that? But of course, in a patient who has a prostate cancer and recurrent disease, I think the discussion about the testing is not just about maybe PARP inhibitor treatment, it's also looking at whether this person carries that gene that may put other family members at risk. So it's something that maybe you can, discuss with your urologist or your oncologist. And if it feels appropriate, then, we can actually consider referring to genetic counselors to discuss.
Okay, so that beautifully now falls into the next question. I think Sui, this same question from the same person just now with the ovarian cancer. She would like to know, since she hasn't done the BRCA test, how much does it cost and what is the procedure needed, and are there any free tests available, and when will the test be provided, because the friend has tested BRCA for a few years now but still doesn't know the result. Maybe you can comment on that.
So firstly, the friend who has done the test, perhaps it could have been under a study or something, but you know, please do come forward. We've put the contact details so that we are able to clarify, because we need to know in which study in particular, but usually they would already have been counseled and given the results. Typically, the cost of the germline BRCA testing is between 1,005 to maybe up till 3,500, depending on which testing service provider does it. But more importantly is to make sure that you get the right discussion going about the test itself first and the implications. And I'm sorry, I didn't get the part about time. It's usually not in years. I think now the results are within weeks, so that if a decision is necessary for treatment options, that can be done within weeks.
Yes, and I think that also follows through one of the questions that the listeners were asking about. Should they do the test before their surgeries, you know, upfront, so that they can do bilateral mastectomy at the point of the primary treatment? So I think you just answered that question.
Yeah, so that also has an additional part. If it's the issue sometimes is the decision is not easy to make when a new diagnosis has just been given. I mean, usually patients are quite overwhelmed already with an initial diagnosis, but it always helps that when the caregiver at the front caregiver mentions it first, and then it's followed up subsequently with another further discussion, not in the same conversation as breaking the diagnosis, but certainly a close follow-up to that on a dedicated conversation on just a genetic test. Then that can be done quite efficiently, and it may be useful, because there will be individuals that may want to use that information for surgical decisions.
Okay, all right. So there's some questions about if they have stage 4 breast cancer, when is it that they need to do the BRCA test? Maybe Prof or Marniza, both of you all can take this question.
I do feel that if the insurance issue is not compromised, that and patient can afford it, because he can do the BRCA test at CRM for 1,500 ringgit, we should try to encourage people to do the BRCA test, because it has therapeutic implication as well as prognostic implication.
Yeah, and at the moment there's a patient-assisted program, right, available only for certain type of patients, right?
Yeah, so now for stage 4 BRCA mutated positive breast cancer patients, we can apply for talazoparib for free. So if a patient has stage 4 breast cancer, should test for BRCA, because at this particular moment, talazoparib is offered for free. You know, these kind of drugs are usually very expensive.
The second line, not the first treatment, but if they have failed or progressed on the first treatment, then they will be eligible for this patient assistance program, right?
Yeah, there is one line. Yeah.
Okay, all right. So I think we've got some more questions that maybe, because we were talking about insurances now, there was a question. I think Sui, could you take this? Because hi, thank you for the talks today. I'm a HER2 positive breast cancer patient. My girl will be turning 4 next month. I'm interested in genetic testing for my girl, but I'm really worried about impacting her insurance. Are there any protection we can have against insurance companies from gaining access to the results of genetic testing? Thank you.
Okay, I thought I heard you say her daughter is turning 4, as in like 4 years old. So these are adult conditions, and we usually typically do not recommend the BRCA testing for a minor. So in Malaysia, because 21 is considered the adulthood, normally we test those that are 21 and above. But in certain situations where we can see from the family history, they are very young cancers. So even in their late teens, and if they are mature, we will be discussing if there is actually an inherited predisposition in the family. But in terms of insurance, so I think it's a gray area, because the platform for insurance, the onus is if the insurers ask directly, then you have to respond as accurately as possible. So but for someone, let's say someone who already has cancer and is not intending to increase, or may be difficult to increase the insurance, then they may, you know, go ahead and do the test because it's not going to impact the insurance per se. But for a relative, say wants to do an unaffected individual who wants to do a genetic test, and they do need to be careful when they do the test, because if they say take up insurance after they have done the test, then the insurance may ask them directly, have you done a genetic test? But it has to be a direct question, have you done a genetic test? And if they have, then they will have to declare it. The insurance are not supposed to ask for their relatives' genetic test. They can ask for the individual who's applying for the policy, because you're not allowed to disclose anybody else's information. So, but for your own information, if they do ask directly, then it may be something that you will have to disclose. So in our counseling, we are quite careful to mention that, so that individuals who are unaffected in particular and planning to have a genetic test, to consider carefully first whether the sequence of when they do the genetic test in that sense.
I think, okay, so the insurance coverage appears that in Malaysia, we don't have any protection against genetic information discrimination, right? So the space is open. Nobody knows what will happen. Nobody has been sued or anything. But if you already have insurance, then you can, if you take a test after you already have insurance, you don't have to inform the insurance company, is it?
Yeah, I mean, from our discussions with like Liam and PM, so what they say is if the policy is already in place, they can't negate on it, because at the point of getting the policy, you are honest by not having your genetic test done. But this may change if, let's say, even with the policy, and then you decide to double your policy, they may ask again for you to have a renewal contract. And at that point, they may ask you again. So it really depends on the situation of what was in the original policy in the first place.
Okay, thanks. Okay, we have some questions about testing criteria, because some of the patients, they are survivors and they were diagnosed at the age of 45. So when is it that we need to test? What is the age band that we need to test? So can I invite Datin Paduka, Prof Teo? Can you answer this question? Because I think you gave a very good talk this morning to the clinician group. Would you like to take that question?
Hi, Aishah. Yes, I'm here. Sorry, what was the question?
Okay, the question is, there were two patients. Both of them are at about 45 years of age. Okay, they've completed their treatments. The first patient was diagnosed in 2015, stage 2 triple positive breast cancer. She completed her chemo, radiotherapy, and now on tamoxifen, and then switched to Femara. And she also had bilateral oophorectomy. So she's still on follow-up, but she's not done any genetic test as yet. So would the person be fulfilling the criteria for testing?
I think it really depends on what's the objective of testing. So, you know, in the past, the objective of testing was to enable people to know what is their risk of future cancers, and to enable relatives to also know what their risk of cancer is, and what type of screening is appropriate for them if they are a carrier. And I think those two still continue to hold true, so that if you are a cancer patient and you have all the risk factors, that means you develop cancer at an early age, or if you develop bilateral breast cancer, or you develop triple negative breast cancer, or if you have family members that have ovarian cancer, prostate cancer, pancreatic cancer, or male breast cancer, all of these are what we call risk factors to identify BRCA carriers. So if you have any of them, if you're under the age of 45, if you develop bilateral breast cancer at any age, if you develop triple negative breast cancer, especially under the age of 60, if you have any relatives that have ovarian cancer, prostate cancer, or metastatic or for pancreatic cancer, those then are all the indications to enable you to see whether you have a BRCA gene mutation for the purposes of risk management. So if you want to do risk management and be able to know what screening is appropriate for you, then I think if you have those features,
I think Sue's connection has gone off. So I think the short answer to that question is if you're 45 and below and you have breast cancer, so that itself is a criteria for genetic testing, and that criteria is mainly to see whether you have the gene, and it could help you with your risk management for the future for new cancers, because we know that you may be at risk of ovarian cancer, for example, or contralateral breast cancer, and also for family members to do predictive testing. That means once the person who have cancer has tested, then the family members can also test. And for some companies, this test is free, you know. So you might want to say something later, but yes, 45 years and above is actually the age group that you should consider testing. All right, I have some questions for Prof. Kartini. Okay, Prof. Kartini, yours, oh, actually it was for me, but I give it to you because your slide mentions, it was my slide lah. Actually, the CPG mentions that age 50 to 70 should go for examination every 2 years. What about those above 70? My mom is 71. Since my grandma had breast cancer, does my mom still need to do mammogram every 2 years or annually?
I think the latest CPG says if you're the average risk general population, it's once every 2 years, 50 to 74 years old. But once you, after 75 years old, it should continue as long as the subject has more than 10 years of lifespan of good health. But if you're 72, I think the question is the mother is 72 years old. So you would,
so
sorry,
her
72.
Her mother has a family history of breast cancer in her mother's mother lah.
Yeah, okay. I think that you would have to check whether you're still in the average risk, or if it's moderate risk, then it becomes annually until they are 60 onwards. But even the after 60 years old, you still do it once every 2 years.
Okay, so I think to this lady, I mean the mom may not be at risk if her mother developed cancer beyond the age of 50. I mean, not no risk, but now this is not high risk, but it's moderate risk. And if you have this, you can actually do annual mammograms. And if your mom is still healthy, she's got a good life expectancy, you know, like she doesn't have heart failure or heart disease, she can actually continue doing mammograms every year
until 80 years old.
Until she's you know, the reason why we do screening is to detect something that can be treated, you know, something that should be treated. Because if someone develops a cancer that doesn't affect their lifespan, like someone with a heart problem, having a mammogram, you see a pre-cancer that may not affect their lifespan at all, it actually causes more harm to the patient. So that discussion, you can actually go and see a doctor, like you can see a breast surgeon or a general practitioner, and see what would be the recommendation for your mom.
Can I just point out, it's not primarily dependent on risk. It also dependent on the results of the mammogram prior to the preceding mammogram. If you have some unstable findings like calcifications or anything that warrants a follow-up, it may be converted to a 6 months or yearly instead of the 2 yearly. You only do 2 yearly to this population if the mammograms are normal. But if there are something that needs follow-up surveillance, it would be reduced to either 6 monthly or a yearly. And alternatively, it can be straight, goes to intervention like biopsy or excision surgery.
Okay, thank you. I think that's a good point. Okay, and then the other question was, can a bone scan test and a CT scan need to have gap time in between? That means, you know, when survivors have all these tests, can they do it close to each other? Bone scan as well as CT scan?
CT scan, that should be no problem. Bone scan, you just want to check the density of the bone. That's also a radio that uses radiation, but the CT scan is usually mandatory for staging. So usually that will be more primary and important than the other scanning. So if you need to do the staging, if they require bone CT scan, that would have to be arranged at appropriate times of the.
But it can be done together lah.
Yes,
Both
yes, yes.
The CTCM can be done together. Okay, actually Dr. Eddie and Prof a lot of questions on diet. Maybe I should answer this one before you all start the diet questions. Okay, so there's a patient who asked, I'm 60 years old, breast cancer survivor for more than 12 years, BCIS and LCIS in the right breast. You have to move both breasts to prevent breast cancer recurrence. Okay, so this question, we have to separate. When someone is followed up after they have survived cancer for a long time, they may detect a new cancer, you know, it's not a cancer recurrence. Okay, so you have to differentiate between a recurrence and a new cancer. So for you, since you've already survived for more than 12 years, there is no reason to remove your breast to reduce risk of recurrence. Okay? But let's say you have a very strong family history, mother, sister, daughter, auntie, cousins have breast cancer. That means your risk of having another cancer on the other side is actually quite high. If you opt for what we call risk-reducing mastectomy to reduce risk of a new cancer for the other breast, then that's the only time there's an indication to have surgery on the other side. Okay, I hope that answers your question. So I think we'll go to Prof Ho and Dr. Eddie's questions. Maybe Dr. Eddie, salmon considered red meat?
Salmon is not considered a red meat. Okay, so the question is not whether it's a red meat or not a red meat. Okay, is considered whether this food is suitable to be taken. I figure more strict. Should be suitable to be taken by human being or not. Okay, when you know that salmon has been put dye to make it pinkish color, when you know that it's a saturated fat is there, when you know that it's inflammatory food to increase the alginic acid. Okay, I think inflammation is one of the triggering factor for promotion of cancer cell as well. Okay, so if you want to take omega-3, okay, there are many sources that you can take. Flaxseed, chia seed actually contain more omega-3 compared to the fish. Okay, as I said, the fish get the omega-3 all come from plant source. Okay, so go for chia seed and flaxseed. You want to go for protein in the salmon, then you can go for bean, tofu, nuts. They have a lot of protein. It's enough. Actually, we Malaysia, okay, generally we are not suffer from protein deficiency. We are suffering from fibers deficiency. Okay,
Yeah.
from the young until now, okay, I think most people never know a friend suffer from protein deficiency unless you have pathological problem. Okay, but since young until now, we always worry about protein deficiency, even though we never seen somebody get protein deficiency. Okay, we are suffer from fiber deficiency.
Okay, good point. I think even we have a Malaysia breast cancer cohort study. Our patient that breast cancer survivor fiber intake is actually very low. So I think I don't know, maybe it's just that we don't like to eat our vegetables and right?
There's a way.
There's a nice question here that follows through. Does this mean we should advocate pure vegetarian diet for everyone? So that's a strong statement there. What do you think?
Everyone, okay, should take a low-fat, high-fibers diet. Low-fat, high-fiber diet means indirectly it's a plant-based diet. Okay, if you look at the plate, okay, there's half veggie and fruits, no controversial. Another 1/4 whole grain, no controversial. Only the 25% protein, whether it come from animal protein or plant protein or not. Okay, so it's the only 25% we are talking about. Okay, so if you can change the 25%, you can definitely reduce the chance of get all kind of chronic disease, including cancer. I must say that I feel a bit regretted in the way that we doctors actually are not helping much in Malaysian people in chronic diseases. For the past 10 years, we are getting more and more, despite we have advancement in new drug, new technology, we're still getting more and more. When now COVID comes, we get worse and worse because the mortality rate is higher when we have chronic diseases. But how to control chronic diseases? Majority are lifestyle and diet.
Yeah, true.
Okay? So if you can juggle or take care of your desire, okay, go for plant-based diet. Follow the plate method. Don't worry about calcium, zinc, magnesium. they all are inside already. You don't even need to memorize it.
Maybe you can share with us how much is the volume of vegetables and fruits you need to take in a day?
Yes. Now, if, according to a conventional, they say 5 parts of vegetables and fruit, right? 3 parts of vegetable, 2 parts of fruits. Okay. I'm not going to tell you what parts is how much, you know, all these things. If you follow the plate, method, okay, just like when we go outside to eat, okay, we never measure how heavy the food we eat, right? We just based on the plate. So if you follow the plate, strict to no processed food and low fat, you just eat it, no worry. You still get thinner, okay, you still get healthier. You just eat it, no worry. No need to calculate at all. You just follow the plate method, okay? You can tell yourself how many plates you can eat.
I'm going to ask you a very controversial question. Actually, it's not in the questions, but this is because Prof brought it up during our MDT the other day. It's about ketosis and cancer prevention. So any comments on that?
Okay, I do have a study that do give some the diet about, especially on the brain tumor part, ketogenic diet. Okay, I'm not a doctor to treat oncology. Okay, but I can tell you that in terms of lifestyle, this American College of Lifestyle and Medicine, actually they are developing with a lot of different colleges together. We are not favored for ketogenic diet. I'm not talking about treatment. Treatment is your field. In general well-being, we found that ketogenic diet corresponded to shorter lifespan. Okay, and then in the beginning, there are some improvement. But later part they lead to different type of chronic diseases. Okay, especially cardiovascular. Okay, you can imagine 1 spoon, because ketogenic diet they need to take a lot of oil, right? Oil. Okay. 1 tablespoon of corn oil, the calorie is almost equal to 5 to 8 corn. Okay, okay. So if you eat 5 to 8 corn, you eat until you're full. You also cannot finish the corn. Okay, but you eat 1 spoon of oil, you finish the oil. So indirectly, you take the oil with calorie, but without other nutrient. How about other nutrient? So you have to take from other food to get the nutrient. So definitely combined, you get high calorie, total high calorie. If you eat corn, day and night eat corn, okay, eat until you get full, okay, you get enough calorie. At the same time, you also get protein, carbo, mineral, vitamin. At the same time, as a package, you eat together. That's how you can give yourself a healthy body. You understand the logic behind? So you get calorie, but without other nutrient, then you need to take other food to get nutrient to end up high calorie.
Dense food lah. That means
yes, we need to take nutrient dense food, not calorie dense food. Nutrient dense food definitions means it's a ratio between the energy you're getting and the nutrient you're getting. So the high nutrient, low calorie, you just eat it, you will not get fat. At the same time, you get enough nutrient.
Okay, thank you. I think there are a lot of questions about green tea, turmeric. I'm not sure whether we can go through that because we're almost at 5 o'clock point because we have technical people who finish at 5. Just to wrap up in the forum aspects of questions that asking about videos, are there videos on our recordings and all this. After this, we are going to ask permission from all the speakers. If they are happy to say that they allow their lectures to be put on videos, our plan was actually to put it on YouTube. So we want to democratize knowledge to our people, right? So that's how we will ask permissions from the speakers first. I think we'll just have to put our hands together for all the speakers today for contributing, and for all of you participants. It's almost unbelievable that we still have about 222 people logged on. We had, I think the maximum was about 270, if I'm not mistaken just now. I'm going to pass it back to Shah.
Yes, thank you, Prof. Ladies and gentlemen, here we are at the end of our public forum. Hope it was most insightful and interesting to everyone. We would like to thank our panel of speakers for being part of these forums and sharing their knowledge in their respective field of expertise with regards to making the smart decision on the genetic testing. Our workshop would not have been a success without the presence of all of you. Hence, we would like to thank you for your valuable contribution and also active participation throughout the forum, especially during the Q&A questions. We would like to thank you to all the secretariats and also our Faculty of Medicine Visibility team for their dedication and hard work in ensuring that our forum is a success. Once again, thank you and have a wonderful weekend. Stay safe, everyone. Thank you. Assalamualaikum.
Assalamualaikum. Bye-bye.